Committee on Aging meeting. We'll have a roll call.
Peggy Bellin.
Here.
Claude Benedict.
Here.
Lurton Blassingame.
Here.
Ron Durkop.
Here.
Sandy Kleckel.
Here.
Judy Ritchie.
Here.
Julie Maslowski.
Here.
Deb Allison Osby. Jean Wallerman.
Here.
Sue Ashton.
Here. Okay. I'm going to take this just a little bit out of order. We have a new member on our committee, Sue Ashton, retired public health nurse. And Sue, if you could just give us a very brief background.
Oh, gee, Judy, I wish you would have prompted me on this. I was a public health nurse with the county for 26 years, and I worked mostly with the older adult population. So it's just kind of dear to my heart to work with older people. And I worked with my mom and dad, who I think of all the people I ever worked with were some of the hardest clients I've ever dealt with. So I'm glad to be a part of the committee and offer what it is I might have to offer. So thank you.
Well, we're really glad to have you, and having worked with you in the past, this is going to be fun.
I'm looking forward to it.
She makes learning not a bad experience, it's a really good experience, and lots of good things to share. Moving on, we have Chuck Hobley, who is
Battalion chief, yep.
battalion chief with the Oshkosh Fire Department, and he oversees the paramedics and that area of the fire department. So, Chuck?
Thank you. I appreciate the invitation to speak to your committee today. I was asked just to give an overview of the ambulance service with the fire department. It is municipality's responsibility to provide ambulance service, fire protection, police protection for the communities that they oversee. And so in Oshkosh, that is something that's provided by the fire department. In larger cities across the state and across the country, that is not uncommon. But there are other methods as well, and you may know that, for example, Lena, Menasha, and Appleton, they have Gold Cross Ambulance, which is an agency that is owned by regional hospitals in the area. And so that's what those cities elect to do when it comes to providing ambulance service for their communities. But it is not uncommon for the fire department to do that. Oshkosh has been doing that. I'll give you a little history behind that. As the person who oversees the emergency medical services and the ambulance, I can say, okay, I could say, you know, without a doubt in my mind, that the service that we provide is second to none. And also that in the 23 years that I've been in the department, the service that we provide right now, the quality of care, the medical direction that we have, the training of the paramedics, we are as good as we have ever been in my 23 years of the department. So we really are, I think, a top-notch service in the state, and I would put us up against anybody in the country. And I'm proud to say that. It's fun to come to work every day because we have great people that we work with, great rapport with the agencies outside, with the hospitals and things like that. It really is a pleasure to work with the paramedics that I work with. So I have a PowerPoint that I'll use more as an outline, but I have a couple of pictures in there as well to share with you. Just a little bit of a history from the fire department. The fire department was organized actually in October of 1856. So 12 years ago already, we celebrated our sesquicentennial anniversary, 150-year anniversary. We got the ambulance service May 6th, 1976 at 10 o'clock at night. Kind of an interesting story behind that. There were private ambulance services in Oshkosh prior to that. And the last one that was in service prior to the fire department taking it over was one called Friars. And Friars, you know, honestly, running an ambulance service is not a money-making proposition. It is expensive to do it, and Friars was looking for a subsidy from the city back at that time. And the city council elected not to provide a subsidy to Friars, and they essentially said, okay, tonight at 10 o'clock, we're turning off the lights. And they went over to the fire department and said, at 10 o'clock, you're in the ambulance business. So they had some people who were trained in first aid and a few who were EMTs, and they put some equipment in the back of a station wagon. And that really is how the ambulance started in the city of Oshkosh. So we were in it. That's our first ambulance that we actually bought from Friars. That's at the current Station 15, which is down at CP and Court Street. We were in the business with EMTs, and I'll explain the training level here in just a minute, but we were in the in the business with EMTs until 1979, and we decided at that point we were going to be in it for the long haul, and so we went through paramedic training. So when it comes to emergency medical services, there are really 3 levels of training. The first is emergency medical responder, and those are the personnel that we have who are not paramedics who work on fire companies. So the lieutenants on the fire companies, they are emergency medical responders. Also, the volunteers that we work with in Omro and Winneconne and the townships surrounding Oshkosh, they are emergency medical responders also. The technical college system in the state of Wisconsin is the entity that provides training for these levels. And so emergency medical responder is about an 80-hour course that people go to for 4 hours a night for about 20 different classes, and they get that certification. They do basic life support. They can use an AED. They provide CPR for people who are in cardiac arrest. They can splint, stop bleeding, apply oxygen, those kind of things. A step above that is emergency medical technician, or EMT. You may have heard that term. That's about 160 to 200 hours worth of training, again through Fox Valley Technical College. And then a big step above that is paramedic. And paramedic is about 1,500 hours of training. And that is done also at Fox Valley Tech, but a lot of clinical hours that are spent in clinics, hospitals, emergency departments, things like that. So Oshkosh decided in 1979 that we were going to go ahead and become a paramedic level service, which is the highest of the pre-hospital providers. And so we started our training in January of 1979. At that point, paramedic training was in its infancy in the state of Wisconsin, so it was kind of something that was developed as they went along. So it was a collaboration between the Oshkosh Fire Department, Mercy Medical Center, and back in that day it was known as Fox Valley Technical Institute, not Technical College. And it took 2 years to do the training, and so we started our paramedic service in January of 1981. And we call this the Dirty Dozen. That's the first paramedic class that graduated from Mercy Medical Center and Fox Valley Technical Institute back at the time. So there were 12 paramedics when we first started. Of the people in that picture, the young gentleman in the back, if you see the man standing in the gray suit, just below him, that's Kevin Girardin. He's still on the job. He is retiring in about 10 days. And I think his retirement date is June 18th, and that will be to the day his 40-year anniversary on the fire department. So he will have been employed with the Oshkosh Fire Department for 40 years. So he was one of the original Dirty Dozen. He hasn't been a paramedic for a few years because he's been a lieutenant on an engine, but he's kind of been a mentor to all of us, and we're going to miss his knowledge and his stories and his experience here when he retires. So in the city, we have 6 fire stations spread geographically throughout the city. I'll show you an illustration of that in just a moment. But essentially, we have 3 primary ambulances. Ambulances are staffed with 2 paramedics, and those, again, are spread about the city so that we can get coverage and we kind of spread the wealth when it comes to the number of calls that we go on any particular day. So we have 3 primary ambulances. If it gets busy, we maintain our paramedic training, and the paramedics work on the fire engines as well. So a couple good things about that. First off, if a truck shows up in front of your house that says Oshkosh Fire Department on it, a paramedic gets off. Even if it's a ladder truck, a rescue truck, a fire engine, there are paramedics on those trucks. They're also equipped, the same as the ambulances are. We really are bringing the emergency department to you. So anything that they would do in the first 15, 20, 30 minutes of treatment in an emergency department, we are bringing to your home. And the paramedics and the fire engines and the fire trucks have that equipment as well. The other thing with that training is that if the 3 primary ambulances are busy and we get a 4th or a 5th or a 6th call in the city, the paramedics who are assigned to a fire engine will take that fire engine out of service, and they are paired with another ambulance. So we can put more ambulances on the street if we need to. And that happens once in a while. We may get 4 or 5 ambulances on the road. It doesn't happen more often than that. A whole lot, but we do have that backup built into the system, which really keeps our system robust when it comes to providing coverage across the city. We have 2 Quint companies. A Quint is a big ladder truck. So when you see one of those driving around, those are known as Quints. It's just fire terminology as far as the equipment that they have on them. A rescue company that's stationed downtown at CP and Court Street. That is a kind of like a moving toolbox, we say, but it's a vehicle that carries kind of one of every, or the only one of things that we have on the department. So that responds to all structure fires, car accidents, gas leaks, things like that. So we have the Jaws of Life are on that, extrication tools, things like that are on the rescue company. And then a duty chief, who's a battalion chief like I am, they're shift commanders. So our minimum staffing at any point in time is 27 people. At any point in time in the 6 stations around the city, there are 27 people that are on duty. Sometimes we're a little over that, but we have to have that built into the system just in case we have to cover someone who's sick or vacation or things like that. So our shifts work 24 on, 48 off. So 24 hours on and 48 hours off. We start at 7 o'clock in the morning and work a 24-hour shift. And then personnel are off for 48 hours. And so we call them A, B, and C shift. So if today is A shift, they started at 7 o'clock. They will work till 7 tomorrow morning, and then they will be off Wednesday and Thursday and come back Friday morning. And so that is just a shift that rotates forever. We don't have any built-in days off other than vacation. So the average work week when it comes to that is is 56 hours per week. Some people give us a little flack once in a while because we get to sleep at work. We sleep at work unless we have calls, and the ambulances, it's unusual for an ambulance to sleep through the night. The paramedics are up usually at least once and sometimes 2 or 3 times in the middle of the night. The other thing is if you use that staffing model, it cuts down your staffing costs by about 25%. If you would have shifts where you would work 8 or 10 or 12 hours, you need 25% more people to do it. So it really is cost effective for the city to work 24-hour shifts instead of doing it in regular shift work. We do a rotation with our paramedics. So the paramedics work 4 work days, 4 24-hour shifts on the ambulance, and then they rotate to a fire truck. So we are not just paramedics or we are not just firefighters. We do both. We're cross-trained. And the ambulances are busy than the fire trucks are. They have a little bit more of a workload when it comes to transporting patients to the hospital, doing the reports that are associated with that, and so on. And so it's just a nice rotation that you work 4 days on the ambulance and then you work 4 days on a fire truck. Back and forth. It's just not as busy. Keeps us fresher. It's a good rotation that we have that I think adds to the level of care that we provide. So types of incidents that we had. This is in 2017. So when you look at the total number of calls that we have had, structure fires where a house or a building was on fire, we had 49. So about 1 a week. Other fires that might be, a garbage fire, a car fire, something like that, 83. When you look at ambulance calls, 7,283. So it really is the lion's share of what we do. This isn't everything really all encompassing when it comes to all of our calls. So I can tell you that the ambulance service is about 85% of what we do. And that's a pretty good national average. For fire departments that have the ambulance service, 85% of the calls that they go on are medically related. We use something called medical priority dispatch. So people ask, why do you send a fire truck with an ambulance? We don't always. But based on the questions that are asked by the 911 center when you call 911, they can get a general idea of how serious the situation is, based on whether or not you are awake or not awake, if you are having trouble breathing, those kind of things. And so that will determine whether or not we send a fire truck with the ambulance and if they go lights and siren or not. And so we code them A through E. A is the least serious, so something like a sprained ankle, a bloody nose, something like that would be considered an A ATEM response, and something like cardiac arrest on the other end of the scale, where someone is not breathing, or a drowning, an electrocution, something like that. That is what's called an E response or an Edward response. So we do send ambulances actually about between 30 and 40% of the time to a house or to a nursing home or something like that, and they do not respond with their lights and siren. It just the situation that we are responding to is one that time is not of the essence, and so we don't put our people at risk and we don't put the other citizens at risk by traveling lights and siren. And studies are showing that by going lights and siren, especially in an urban setting, we're really only saving a few seconds, less than a minute, about 45 seconds if you're doing it in an urban kind of setting. And so we're trying to decrease the risk to our people and the citizens by just not responding with lights and siren as much as we used to. Coverage area, in 2003, we started to cover areas outside of the city of Oshkosh. Amaro and Winneconne are the largest of those, but we cover the townships around the area as well. I won't read through each of those, but it adds about 25,000 onto the population. So Oshkosh has a population of about 66,000, and then the contracted area as well adds a population of about another 25,000. When you look at the calls from 2017, 85% of those were in the city and 15% were outside of the city. But that's just a service that needed to be provided. When we started doing that back in 2003, when you look at the numbers, it increased the amount of time that an ambulance is available to the residents in the city of Oshkosh, and at the same time is providing that level of service out into the county as well. Just a very quick description or an illustration of where the fire stations are located in Oshkosh. So anything that's yellow is within the city limits, and then we have the fire stations spread nicely throughout the city. The primary ambulances are at stations 15 at CP Court, station 16, which is 9th and 41, and then station 17, which is Algoma and Murdoch. So that's the kind of triangulated there, and those are the stations where the ambulances are that provide the primary ambulance coverage. It's a little hard to see on this slide, but you can see there's a yellow outline. And essentially, if you take anything south of the water, Lake Poygan, Lake Butamore, anything south of that is the ambulance coverage area that we have. The one exception is in the southwestern part of the county to the town of Nepieskin. They contract with Berlin EMS for their ambulance service. But that is the contract area that we have for our ambulance coverage. Benchmarks and care that we have provided. In 1998, we started doing something called 12-lead EKGs, where the paramedics can actually diagnose someone having a heart attack in their house. And we were the third ambulance service in the state of Wisconsin that did that. Now it's the standard of care, is that everybody does 12-lead EKGs, but we've been doing that for 20 years. Something called CPAP, which assists in people, especially with congestive heart failure or asthma or emphysema, when they are really struggling to breathe. It is something that was made small enough that we can carry on the ambulances and provide ventilation assistance with that. 2002, we did tiered training. So we brought all of our training in-house, all of our medical continuing education. That really is a large part of what I do. But our paramedics and our first responders all do their training on duty. So no overtime is required for them to get their training done. And it's something that we do with a handshake agreement with Fox Valley Technical College. So the training in addition to that doesn't cost the city anything. Priority dispatch, that's the ABCDE that I was talking about. We started that in 2003. We started computer reporting in 2003, which was a big changeover. Prior to that, we were doing everything with paper and pen. The nice thing about computer reporting is that we can get a lot of statistics. So a lot of things that I share with you as far as age of patients and calls that we have and things like that, we can get out of our computer reporting system. Interfacility transports we started in 2003. That is, if a patient is at Aurora and they need to go to St. Luke's and Milwaukee, we will transfer those patients. We'll take them from Mercy up to St. Elizabeth or maybe to a burn center down in Milwaukee or something like that. But when it comes to those long distance transports, those happen about 160 times a year, so a couple times a week. It's not that we're taking ambulances out of the city a whole lot. Rescue trial study was done in 2004. That was just to try to improve ways to perform CPR in patients that are in cardiac arrest. Rapid sequence intubation is administering medications to people who are really struggling to breathe or who cannot protect their airway. And so we actually put them to sleep and then administer paralytics just like they do in the operating room so that we can control their airway. We put a breathing tube down into their lungs and breathe for them. So we've been doing that for just over 10 years. Video laryngoscope is a camera device that we use to do that rapid sequence intubation. And then in December of 2017, we changed our stroke destination protocol for patients that we believe might be having a stroke. Time is of the essence. Time is brain. And most strokes are caused by a clot in a blood vessel somewhere in a patient's brain. And so we have an assessment tool that allows us to identify whether it's a big stroke or a small stroke. And if it's a big stroke, the best thing to do is to take them to a facility that can go in there and vacuum the clot out. And so there are two facilities in the area that do that. One is Theta Care up in Neenah, the former Theta Clark, and the other is St. Elizabeth's up in Appleton. And they don't do it here at Mercy. They don't do it at Aurora here in town. So the most important thing is to realize that those patients are having that big stroke and get them to the location where we can have them hopefully have a complete recovery. And we've been very successful with that. That is definitely something we're pound on our chest a little bit when it comes to the success that we've had with our stroke destination changes and the patient outcomes. So that was a big change that we made just about 6 months ago. Total number of incidents going back to 2009. These are everything. These are fire, ambulance calls, anything. In 2009, we had 7,156. In 2017, you can see that the numbers have ticked up since then, and our total number of calls were 8,867. So that's a pretty significant jump. It's just kind of the nature of what we do, and it's not unique to Oshkosh. That happens all around the country, but the calls of service that we have been getting have been steadily increasing, and we have been able to cover those really without too much of a problem. We're staffed well and equipped well so that we can do that. When you look at the medical calls that we went on, these are what people called 911 for, and these were in 2017. So 20% of the calls that we went on were fall related. People called and said that they had fallen. 1,760. Another was kind of just a generic sick person, people with trouble breathing, car accidents, someone who's unconscious, chest pain, those interfacility transports. And those aren't just long distance. Those might be that we're going from a nursing home to the hospital or a hospital back to a nursing home for someone who's bedridden and isn't able to go in a wheelchair van or something like that. Seizures, traumatic injury, abdominal pains, that's not the entire list, but those are the top 10 or 12 reasons what we were dispatched for in 2017. Patient dispositions. We have more than, I said we had something like 7,600 calls, but we have more patients than that. If we go to a car accident, there might be 3 or 4 people in a vehicle that need assessment. And so if you do the numbers, you'll see that we have more patients actually than we do medical calls, but that's the reason why. ALS treatment and transport is really when the paramedics are using their advanced life support skills. So we are starting IVs, we put people on the heart monitor, we administer medications. So that happens about 36% of the time. Basic life support is more like a sprained ankle or a broken bone, a car accident with minor trauma. That's about 31.5% of the time. And then the number of people that we don't transport, surprisingly, is about 29% of the time we don't transport people. And I'll elaborate on that here in just a moment. Ages of patients. These were from June 1st of 2017 to June 1st of 2018. So just last week I pulled up this data. But you can see once we get people above 51 and up to about 90, that really is the lion's share of the patients that we see. And I think that's expected. The oldest person that we saw in 2000 in that time span was 107, interestingly. So the centurions are out there. Payer mix. I'll just take a minute to explain this. This is the insurance that people have that we transport to the hospital. So commercial insurance is the insurance that I get from the city, or if someone would buy their own insurance policy. In 2017, we'll look at those numbers. Of the people that we transported to the hospital, 11.8% of people had health insurance. Medicaid was about 12.8% of people. Medicare, 65 and over, was about 42% of people. And then private pay really means that they didn't have insurance. So a third of the people that we saw in 2017 didn't have insurance. That's eye-opening. When you look at the number of people in Winnebago County who don't have insurance, last year it was 7.9%. But 33% of the people that we see in the ambulance didn't have insurance. So you got to do a little reading between the lines. I see that as meaning that people are using the ambulance now as their entrance into the medical system. So to call us emergency medical services a large part of the time, actually, especially when you looked at 28% of the time we're not transporting people to the hospital, they are using us as their entrance point into the healthcare system. They don't have primary care physicians. They don't know where to go except for the emergency department. So that's just an interesting statistic. I'm happy to see that went down a little bit between 2012 and 2017. I hope that means that some of the things that are being done in the community with the fire department as well are helping with that, but that's still a big number when you look at the number of people who don't have insurance. And when you look at what the trend is, fewer people have commercial insurance, more people are on Medicaid, more people are on Medicare. From a a revenue standpoint, we certainly don't make money by having the ambulance service, but we use the money that we have to offset our costs. From a revenue standpoint, it's decreasing the revenue that the city is taking in. That's the nature of the beast. I think it's important that we don't look at the ambulance service as a means to generate funds for the city. Again, we use it to offset our costs, but it is a service. Excuse me, I got a frog in my throat. It is a service that is needed in the city, and so there is a cost. When you cost it out, really, the fire chief has done this in preparing to sign a contract again with the outlying communities. For us to have the ambulance service in the city, when you take the cost for the paramedics minus the revenue that we generate, the cost is about $263,000 a year. That is really small. When you're looking at we have 9 ambulances, a mechanic who works on those, my salary for overseeing that and doing the training, and 18 paramedics, and the cost to the city total is $263,000. That's a fantastic bargain. And then again, just to reiterate, the quality of the paramedics and the quality of care that we provide, I think really is a great illustration of the deal that it is for the city of Oshkosh. Ambulance rates, how much does it cost? If you get an ambulance call, what does it cost? Well, we charge, if you live in the city, if you have a BLS call, a broken bone or something like that, the charge is $600 plus supplies. If it's advanced life support, where you start an IV, use the heart monitor, administer medications, that rate is $700 plus supplies. Supplies, it costs us about $20 to start an IV. That's what the cost is for us. But if we give medications, we have medications that may cost us 50 cents. We have medications that cost us $215 for a dose, depending on what the medication is. The number on the right there, when it's BLS, Medicare will reimburse us $349 regardless of what our cost is. So when we transport people to the hospital and it's termed BLS, basic life support, we get $349. For an ALS call, they'll reimburse $414. Okay? When you look at Medicaid is about a third of that. So BLS is just over $100 that we get reimbursed from Medicaid, and ALS is about $125 or $130 that we get reimbursed. And we cannot bill the patient for the balance. If we accept Medicare and Medicaid, we have to accept that amount, and we cannot bill for the balance. Those are federal laws when it comes to billing for ambulance. Non-residents, it's $100 per call higher. If we would take care of you on scene but not transport you. ALS on scene, an example of that would be something like a diabetic whose blood sugar is low. We start an IV and administer a medication to get your blood sugar back up, and you don't want to go to the hospital. The cost is $400 plus supplies. Basic life support, that's more than just a Band-Aid. That is somebody who's using the ambulance as a way out of going to the hospital. In that case, we would bill $250. Medicare allows us to charge $15 per mile. That's a loaded mile. So if we're going to the hospital, for every mile that we transport, we charge $15 a mile. And the lift assist, which is a charge that was implemented in 2017, if we go to your house and you have fallen and you need assistance getting up, there's a $50 charge for that. The first one each year is free, but that was needed. Really, I'll tell you why. Assisted livings have been using us to supplement their staff. And so we go to assisted living facilities multiple times a day because someone has fallen, and their intent really is not that we're going to take them to the hospital, but that we just are going to supplement their staff to get somebody up because they don't have the training to get somebody off the floor, or to do a medical check to maybe take the liability off the staff that is there because they have minimal first aid training. And so they are using us a lot for that. Again, that's not unique to Oshkosh. That is a state and a nationwide issue. But it is, I shouldn't say it's not uncommon, but there are assisted living facilities in the city that we go to 2, 3, 4 times a day to provide services like this. And so in an effort to cover costs when it comes to doing that, City Council directed the fire chief to implement a $50 lift assist fee. That goes directly to the assisted living facility. Unfortunately, I think that gets passed on to the resident. I don't think the assisted living facility is paying that out of their pocket. And if we go multiple times to a residence for someone who has fallen, they get the $50 charge as well. So that is how our ambulance billing breaks down. When you look at the amount that we bill versus the amount that we can collect, it's about 50%. So for every $100 we bill, the city gets about 50. And our ambulance revenue in 2017 was just over $2 million, and our cost to provide the service was about $2,300,000. So that's the $263,000 of the cost that was borne by the taxpayers in the city and the surrounding communities for the ambulance. Just a few things when it comes to ambulance service here, and then I can open it up for questions. Medical necessity is something that is big with Medicare and Medicaid, and insurance companies are adopting this now. But really, we can point our finger at the federal government when it comes to talking about medical necessity. When it comes to Medicare, Medicare says that patients need to know what their coverage is, first of all, and you cannot just take an ambulance for anything. It needs to be medically necessary, and that has to be the most appropriate means for transport. So if you're having stroke-like symptoms or chest pain or a broken hip or something like that, of course that is medically necessary. But if you've had knee pain for 6 or 7 days and you think you need to go and have it checked out, Medicare will not cover that. And so you will get a notice that says that Medicare doesn't cover that, and then you get the full bill. You don't get the Medicare amount, you get the full bill, which usually is somewhere between $700 and $1,000, depending on how far we transported you. So that is something that I deal with quite regularly about medical necessity. Nursing homes that call because a doctor says a patient has abnormal lab values and they need to be seen in the emergency department, so call the ambulance. Medicare sees that as not being medically necessary. If you don't have signs and symptoms of an illness, even if you have abnormal lab values, Medicare is not going to pay the ambulance bill. So the patient gets stuck with that. We try to do some education as far as that goes. It doesn't go very far. Doctors really don't understand that even if they order a transport, Medicare is going to review every call that we do, and if they say, nope, they were sitting in a wheelchair when the ambulance got there, they will not cover it. Okay, and that's just a nature of the beast. One of the points of education that we need to do. So if you've had a headache for 5 days and you think you need to go to the hospital and an ambulance is your only choice, you are going to get the bill. Medicare is they're sticklers about that. They are not going to waive that fee, or they're not going to cover that fee. They are going to they're going to make you pay it. The other thing is I mentioned the on-scene care. And I think this is a flaw in the system, but if you are a diabetic and you are on Medicare, if we come to your house and we start an IV and we give you some medication to bring your blood sugar up and you don't want to go to the hospital, Medicare will not pay that. Medicare will only pay the ambulance bill if we transport you. And so you will get a $400 bill. We save the system thousands of dollars because we are not transporting you to the hospital. You do not get the hospital bill. You do not get the physician bill for being in the emergency department. Medicare doesn't care. They won't pay it. And so that goes directly to the patient. So I have had personal experiences where we go to a diabetic one time, we treat them and release them. The next time we go there, there was a husband on one case who said he wasn't worried about his wife. He said, you take her to the hospital because the last time you didn't take her, I got a bill and I want to make sure the bill is paid. And if we would transport her, even though we would solve the problem in the living room, if we transport her, then Medicare will pay the bill. So that is a flaw in the system. But that's just something that we have to live with until hopefully they get that changed. I mentioned the assisted living facilities, and then the bariatric issue. Bariatric means big, like overweight, like really obese. And so we do have a setup where we can transport bariatric patients. Last time I checked, we were using that system about 150 times a year. This is an example of what it looks like. They are ramps because we can't lift these people. We're talking people who are 350 pounds and up. And we get people that size about 3 times a week. And so our regular equipment doesn't handle them, and it's not safe for our personnel to be lifting that much weight. And so there are ramps that hook onto the back of the ambulance. That is a special cot that can handle up to 1,200 pounds. And so the biggest that I'm aware of is about 750 that we have transported. But that is an issue that we deal with and is equipment that we have to use. One question people ask, why is it that you send a fire truck with an ambulance? As I mentioned earlier, we only do that on the higher acuity calls where people, it's more likely that they're going to be significantly sick or injured. And a couple of reasons that we do that. One is, as our fire chief likes to say, he's retiring here in just a couple of days, so I got to call attention to him, Tim Franz, who's been a fantastic leader of our department for 18 years. But he says homes are designed for people to move around while they are upright. And when you are flat on your back, it's a little difficult to move people around. The other thing is, if you take someone like me, I would rather have 4 or 5 people carrying me out of a house if it's needed, as opposed to just 2. And as I mentioned, the paramedics rotate off the ambulances onto the fire trucks. So if you really are having a life-threatening emergency, and we do see those, cardiac arrests and people who are in congestive heart failure or they are in shock or something like that, you get 4 paramedics that are working on you, not 2. And you don't get charged more for having 4 paramedics. It's just built into the system that we have that increased level of care. That's one of the reasons I think that we are as successful as we are. But in those situations, and they happen a few times a day, where we really have life-threatening emergencies, we have that many more trained personnel who are there who can provide that level of coverage, that level of care. So that is the final slide that I have. I hope I stayed within my time limit. I'm a little over, but if you have any questions, I can certainly answer those. Yes.
What's the coordination between ambulances that the hospital provides and the fire department provides?
So the ambulance that the hospital provides is Gold Cross Ambulance, and they are not at Mercy. If you see them at Mercy or you see them in town, they are transporting a patient to one of the hospitals and then probably going back to their stations. There really isn't a coordination. They're the ambulance service for the communities to the north of us. So Neenah and Menasha and Appleton and Grand Chute and so on. And the Oshkosh Fire Department is the ambulance service for the city of Oshkosh and the communities immediately to our west and our south. We work together if we get large incidents. We have mutual aid agreements, so that certainly they would assist us if we would have a traffic accident with numerous people or an issue at EAA where we had dozens of people who were injured, and we train on that kind of stuff regularly. But as far as an integration where we share calls and things like that, there isn't anything like that. Anything else?
Thank you.
Okay, about a year and a half ago, I was at a meeting with you, and you talked about community paramedicine. You want to tell the group a little bit what you were talking about at that time?
Sure. Community paramedicine is a new idea that was started in areas other than Wisconsin. I think it was started on the East Coast first in places like North Carolina. And the idea is that you take paramedics, and instead of them staffing an ambulance, they have a higher level of training, about 400 more hours of training, and they work with hospital staff to go into people's homes as a way to try to stem their need for calling an ambulance so that we can identify issues. One example, it's kind of a unique example, but someone who has congestive heart failure. And the worst thing that you can do if you have congestive heart failure is eat a lot of salt. And so one of the things that a community paramedic does is goes into a home, make sure that the person is taking their medications, make sure that they are not gaining a lot of water weight, that their vital signs are stable, and checks to see what they're eating to make sure that they're not getting too much salt that might put them back in the hospital. That's an example of what community paramedics do. It's done differently. There really isn't a consistent system with the way that community paramedics are being deployed throughout the country. I do know that the Madison Fire Department has a few community paramedics, and the patients that they identified were those that were calling 911 most often. So they just went in their statistics from the previous year and found patients who were calling 911. We get patients that we see 20, 30, 40 times a year, and they would identify those people and then try to go into their homes to see what was causing them to call 911, to see if they could help with that situation. They might do things like fall risk assessments in the home. Do you have throw rugs down? Should you be using a walker? Those kind of things. But it's really hodgepodge around the state as to how EMS agencies and fire departments are deploying this, if they are doing it. The one issue with community paramedicine, there was finally some legislative action passed here within about the last year that allows agencies to provide this, that it's actually overseen by the state of Wisconsin, that there is a curriculum that was developed. But one of the things that they purposely left out was the funding for community paramedics, because it's expensive. We don't have the personnel on staff right now where we could employ this. We can't take away from the 911 response staff that we have so that we would do it. So if we would provide something like community paramedicine, and we don't right now, we would have to hire extra people to do it. And the cost of a paramedic is about $100,000 a year when you look at wages and benefits. And so we would have to recoup those costs. And there is not a cost factor built into any sort of the legislation. The one thing that some places are doing is to work with hospitals to see if hospitals will cover the cost for these community paramedics. It's been lukewarm at best. We haven't tried locally just because we don't have the staffing right now. But for other agencies that have done it, when they go to hospitals looking for staffing assistance, the hospital's interest really hasn't been on point to what we would need to cover the costs. So does that answer your question? It's certainly something that we're aware of. I don't know that I would say that we have a point in the future where we want to start doing this. We're getting a new fire chief here a week from yesterday, so Chief Stanley may have some different ideas when it comes to that. But in my opinion, when it comes to the staffing that we have, right now we don't have the staffing that would allow us to do that. We would have to put extra people on, and that would be expensive. So we need to recover those costs.
Okay, another part is the file of life packets. In the past, those have been widely recommended. Is that the feeling yet?
Yes, those are very helpful to paramedics. And so we do have them at the fire department. If people would like to get those, they can call the fire department and ask for John Holland, who's our public educator, and he can work at getting those out. You can stop by our station at 101 Court Street at the corner of CP and Court if you can make your way around the road construction. We have those available there. Those are very helpful to the paramedics. Just make sure you have them in a conspicuous place. A lot of people, they're magnetized, and a lot of people just stick them to the refrigerator. If you fill them out, do it with pencil, so that as your medications change, or you need to change something as far as allergies or something like that you can erase and put information back on there. But that is really helpful when it comes to getting information. We need to pass that information onto the hospital, and especially when we're dealing with people who might be having a stroke and can't communicate with us, or they are unconscious, to have that information and the medications that they take, the hospital that they would like to go to, that information is all very beneficial. Which, just if I can add one thing onto that, as far as hospitals that we transport to, if you call 911 and you say, I want to go to Aurora, we're going to take you to Aurora. If you say, I want to go to Mercy, we will take you to Mercy. We don't have a predisposed hospital that we would take you to. If you're having a stroke, we would ask your permission to take you somewhere like Theta Care Nina or St. Elizabeth's. Or if you would have serious trauma, we would take you to Theta Care Nina. They're a trauma center. They're a level 2 trauma center. And so they're going to, in our opinion, provide the best care. It's not just our opinion, it's in the state of Wisconsin. And so in those instances, we would ask your permission to take you to those specialty hospitals. But we are not governed by geography or anything like that that says if you're, on 20th Avenue, you have to go to Mercy because it's the closest hospital. That doesn't happen. That's a little bit of a misconception that's out there that I deal with occasionally, and I just want people to know that we will take you wherever you want to go as long as it's within reason. We'll take you to Appleton, we'll take you to Fond du Lac, we'll take you to Berlin or Ripon. We won't take you to Milwaukee or Madison. That's not prudent to do that if you're having an emergency. But anywhere here in the northeastern part of the state, or the valley at least, we will transport you to those hospitals.
With the file of life, one of the things that I recommend folks is to set it up in a word processing on their computer, and to do 2 rather than 1 form in that packet. Because I found, when I was working with Meals on Wheels and even in my apartment building, that when the paramedics are out, and if they've got that, they grab that extra sheet and it goes right with, and there's no misunderstanding as long as it's been updated.
That's a great idea.
And it would be nice if there was a fill in the, computer generated, fill in the form rather than totally setting it up new. But that's something we can do down the line.
That's a good idea. Actually, I don't think that would take a whole lot of work. And so that will be something I'll consider, and maybe I can work with John Holland in doing something like that.
And as we talk about doing things with the Committee on Aging on the city website or possibly Facebook page, but on the website in particular or under senior services would be a great tool to just be able to refer people to that form and just print it off and keep doing. And when I was doing events out in the community, I had parents of young kids wanting it because the kids were home alone. So it's good for any age, not just elders.
That's a great idea. I will take that back and we'll see if we can make something like that happen.
Okay, sounds good. And then could we have you come back another time and talk about the cardiac study that was done with Jim Ostad
Sure.
a few years ago?
You bet.
And demonstrate the Lucas heart compression machine,
Absolutely. I'd be happy to do that.
because there's some really good things that go on with that.
Mhm.
Okay, any other questions?
I had a question for you.
Sure.
Now, when you talk about the community paramedic, have you ever thought of contacting the public health department? Because we have nurses there, and we used to go out and help people in the community with just that problem. Those who were dealing with congestive heart failure and had numerous visits with the doctor, or the family would get upset with their person and couldn't deal with them, then we would come out and try to figure out what is the problem here. And it's like with my dad. I went to see him. His legs were all swollen. I said, "What are you eating, Dad?" He said, "I want you to go to the store for me, and I want you to get me some shrimp and some of that cocktail sauce." Well, I looked on the ingredients and I almost fell over. I said, "No, we're not getting that for you. That's part of your problem here." So anyway, it's just a thought, because that's something we're very tuned into at Public Health.
And those are discussions that have been had, Public Health, the Visiting Nurse Association, those kind of things. The people who are really invested into the community paramedic insist that there's not a duplication of efforts when it comes to those kind of things. I'm not well enough versed to say whether or not there is or there isn't. One of the things, if we would ever implement this, that would be important to me is that our community paramedics would have access to medical records. I think the hospitals would be agreeable to that, but that we would have a computer that we could take with, that we could look at notes that a physician may have put in, or a history and physical, or things like that. I think that would just help us be more in tune with the patient and what their concerns are and things like that. But again, that's a discussion that would happen down the road just because of staffing and costs and things like that. So I have a few ideas when it comes to that, but we'll see where that goes in the future. Yes.
I just have a comment, and it's may or may not be appropriate to mention that, but the paper yesterday had the article on the OPD setting up a database which would track people who could need special assistance when home alone or in an emergency.
Mm-hmm.
And I wonder if in time that might play into some of the emergency response that the fire department is doing.
So we have a means to notify our people, and we can use it for a host of things, whether it is medical issues that people have, if there are developmentally delayed people who are at home, or people who might need special assistance. It's built in through the 911 center, but it's information that in the position that I'm in, I have access to. And so if there is a specific need, an example of one that I put in recently was a patient who has something called the left ventricular assist device. They have such bad heart disease that they need a machine to help their heart pump, and it's important that the paramedics know that. So we put that information in their address. So if you go to that person's address, that information is flagged. We have computers called mobile data computers in all of our fire trucks and all of our ambulances. We get the information on all the questions that the 911 dispatchers ask. That comes over. It gives us the address. It gives us the cross streets. It'll draw us a map on the computer on how to get to an address. But then it's something that's called premise information, and it might be a key code if someone's got a combination lock or something like that to get in. It might be information about their medical history. It might be unique information about, like I said, developmental delays that someone has. So we have that ability right now, and it's something that's available and it's not just to the fire department. It's anybody who would go to that address. So if the police department would go there, they have that information accessible to them as well. So. Mm-hmm.
The other thing, when you get a call to an fire alarm call, to an apartment building, to some of these other facilities, some of the neighbors get a little upset because of the number of fire trucks and ambulances that come out. Can you explain, I mean, I know, but can you explain why?
And are you talking about medical calls or fire calls?
Well, it could be one or the other.
You bet. Well, there are national standards as to personnel that respond to a call. So if we get a call that a house is on fire, we are going to send, it's 13 people, but it gets 3 fire engines, a big truck with a ladder on top, a rescue, an ambulance, and the chief. And so there are 6 or 7 vehicles that go to that. Fires are not safe. A building that's on fire, if a room is on fire, thankfully we don't have a ton of big fires like that. But if we go to a house that is on fire, number one, they double in size every 30 seconds. So from the time that you call, if it takes us 4 minutes to get there, the fire is doubled 8 times, doubled in size. And the products, Hollywood does a terrible job of depicting what a fire is. If we walk into a building, we don't walk, we crawl. But if we crawl into a building that is on fire, you cannot see a thing. It is pitch black. You might as well go out in the country in the middle of the night and walk around, because that's what it looks like. You cannot see the fire. We go towards the fire by the feel of heat and by the sound of where the fire is, and by clues that we get when we pull up on scene, where the most smoke is. I know I have to go to the upstairs or the back of the house or something like that. There are standards that say for every 2 people that are inside a building, 2 people have to be outside of a building in case we would need to rescue them. We send a fire engine, and their only responsibility is to stand by in case firefighters would get in trouble. We call it a RIT team, a rapid intervention team. So their only responsibility is to stand by outside if a building is on fire, that they could perform a rescue of firefighters if they would need to. There are a lot of things that need to be done. And so we always take the worst case scenario. We get dispatched to a lot of structure fires, and it turns out that it's an electrical outlet that was sparking, so it's not a big deal. Or maybe it was a false alarm, or it was something that overheated on the stove or something like that. But the information, people are frantic when they call 911, my oven's on fire, my house is on fire, something like that. So we're going to err on the side of caution and send a lot of resources to that. It's a lot easier and safer for us to turn them around if they are not needed than to get there and go, oh shucks, we need more help, and ask for more help and get those people there. So we dare I say, oversend resources to make sure that we are safe, because when they turn out to be structure fires, when it is a building that's on fire, or there is a gas leak with the potential for explosion, we need that number of people there. A lot of things that happen in the first several minutes of a fire. We get somebody in who's going to work on putting the fire out. We have to get the heat and the smoke out of the building. We have to search for people that might be in there. We have to hook a truck up to a fire hydrant. There have to be people there in case there's someone inside, that the paramedics are there that they can take care of someone. We might have to go to the roof to cut a hole for ventilation. We have to control utilities, so we have to turn off the gas and the electricity. So those are all personnel-heavy tasks that need to be performed, and so that's why we send out the number of people that we do when we get calls like that. And if you look at bigger cities, they send 2 or 3 times the number of people do. We just don't have that many people to send. But for a house that is on fire, it takes that many hands to address those situations, and so we treat it as a worst case scenario.
Thank you. So on that note, any other questions from the group? Thank you.
You're welcome.
We will be inviting you back again.
I'd be happy to come back.
And if you could forward your PowerPoint to Bobby,
I will.
we will share it with our group, and we'll put it on file for later sharing.
Very good.
Thank you.
Thank you.
Okay, I kind of took the meeting a little out of order, so we'll backtrack. We need to have an approval of the May 1st meeting minutes. Any additions or corrections?
I move for approval.
Second.
Okay. Moved and seconded. Any discussion? All those in favor?
Aye.
Opposed? Okay. And citizen statements, Teresa or Tom? Okay. And I will welcome Tom. He is representing the Oshkosh Herald. So we're really glad to have you here. And Teresa is one of the representatives from the Health Department,
From the where?
the Winnebago County Health Department.
Okay, thank you.
We've had increased interest from other entities in the city to be a part of our meetings, or at least take information back to their group and to share with us in the future. Okay, new business. We'll go back to, we need to have an election of officers. This is our new program year. We need a chairman, vice chairman, and secretary. Do we have any nominations?
Yeah, I'd like to nominate Judy Ritchie again for chairperson of the Oshkosh Committee on Aging. And if I could, I don't know if I can do it or not, just close off the elections. I can't do that probably. You know, stop it and say no more nominations for chairperson.
Let's
Oh,
just,
anyway.
let's just get a slate together.
Okay.
Vice, do we have a nomination for, any other nominations for chair? Do we have any nominations for vice chair?
Who's the vice chair now?
No one.
Oh, that's right, that's right,
When
that's right.
Julie resigned at
That's
the
right.
end of the year as vice chair, I was moved up. And in theory, Zandy would have, if we needed a
Yeah.
vice chair in the interim, Zandy would have been the vice chair. She is secretary.
Well, then I would like to nominate Ron
Kirkup.
Hookup. Sure, he's got a knowledge on there.
Second.
Okay.
Are you
And-
willing to run?
Run.
And nominations for
Yes.
secretary.
Doesn't Bobby do much of that?
She is the city, but we have to have a secretary from our group
Name.
Sandy?
in name.
Are you willing to take it?
Any other nominations? So, as we have it right now, nominations are Chairman Judy Ritchie, Vice Chair Ron Durkop, and Secretary Zandy Kleckel. Can we have a motion for that?
So move.
Second?
Second.
Any discussion? All those in favor?
Aye.
Opposed? Okay, you have your officers for the next year. Which means, Ron, I can be sick and you can take over.
You better not
Okay.
be sick too often.
Moving on, and we're going to be moving rather swiftly, I hope, through this. Committee reports, strengthening our partnership with neighborhood associations and other partners. Lurton?
On the 10th of May, I met with the South Menominee neighborhood, and on the 15th, I met with the neighborhood development for their monthly meeting, all the neighborhoods together, explained who we were, why we were interested, how we would hopefully work together, and if they had any questions or ways that they thought we could help them, to either contact me or contact Jean. And I think the file of life would be a interesting and a productive and relatively simple information to get out, to give to the neighborhoods and have them distribute it to everyone, but particularly to their elderly. And the reason, for those who aren't here, we're interested in the elderly throughout the city. The neighborhoods are interested in everybody within their geographic boundary, elderly and not. The overlap is obvious. So I think we're on the right track, and we probably need to follow up on it.
Okay. Improving access to affordable transportation and delivery services for seniors. Peggy or Claude, do you have anything? I have nothing. I really have nothing at this point either. Create community design and policy that supports an age-friendly community. Jean?
Yes. Part of our strategic plan, we've had to identify city ordinances that are applicable to older adults. If you look on the website, you can find, on the city website, you can find the section that does have all of the city ordinances. And just a reminder for the individuals living in residence, in the summer months, this is probably a good time right now. Just part of the city ordinances is the uncut grass, so make sure that all of you that are living in homes that, if your grass is 8 inches or higher, and it's not getting cut, that the city can come and then charge you if they have to cut the grass. So that was one of the ones that I found that would be pertinent to this time of the year. Noise ordinances, again, nighttime hours for noise ordinances, 10 p.m. to 7 a.m., unless if there's like a special permit or something that is given for, because this time of the year, as we start seeing more special events occur in the city, just a reminder. But you can find all the city ordinances on the city website. It's towards the bottom under the quick links, and it's called municipal codes. So you can find tons of codes that are pertinent for this city.
Okay, thank you. Improving communication and visibility of available services to seniors. And Julie and Jean and I met with Tony from the IT department of the city and had a very good meeting. Julie?
Yeah, it's an exciting time because the city of Oshkosh is redesigning their website at this point. And so we're able to get on the front end and have some, add some value to our design on our Committee on Aging site. And also we talked about the Facebook and how we can provide a link to the Facebook page that we're going to create. And so there's a lot of exciting opportunity right now yet to be seen, but we're working on it with Tony. So
Right. With the website would be more long-term information, would be links to a variety, be it the health department, wherever. The other would be, with the Facebook, would be things that are more short-term when we talk about heat awareness or some of we were talking about the Fall Senior Expo, things like that. Better, more efficient ways of getting the information out to the community. So it was a really good meeting.
Mm-hmm.
And Ron, we missed you.
Yeah, very.
Okay, anything else under those committees? All right, moving on, other business. Sue, you've got, I think, 3 different pieces you were going to talk about?
Yeah, just the Wisconsin Heat Awareness Day is actually tomorrow, June 6th. So in the last 5 years, 39 people have died in Wisconsin due to heat. So a lot of these people are kind of isolated. So the big push would be when it's really, really hot, like we had those 90-degree days, like 3 days in a row, would be to check on your neighbors. A lot of people are socially isolated today. They don't have family, they don't have friends around, so just knock on their door, make sure they're okay. A fan really doesn't do a whole lot, You gotta keep hydrated, you gotta drink enough water, and a lot of people that are on medications that are older, they don't think they need to drink, but they do need to drink. If they're able to get out, encourage them to go to like a mall or the library, somewhere where there's air conditioning. But a lot of these people can't get out, so just be aware, and that might save somebody's life. Because it says as much, if people in a car, I just read where now, a few days ago, there was a child in a car. Well, it can be an older person too, so it doesn't take much to do a person in. And the other thing that we want to look at is it's, mosquito, tick, weather. So just be aware, because I know a lot of people with Lyme's disease, and it really takes its toll on a person. So when you're going to go out, put on your sunscreen first, and then apply your insect repellent after that. And they have sprays that go over your clothing now. That's also helpful. And avoid going off the beaten path, like even around your yard. If you have long, tall grass, that's where the ticks hang out. Yeah. And if you've got water standing in pots around your house, or an old tire, or this or that, And change your bird bath every 3 days, they say. You know, my brother says, it's like that all the time. I say, well, you could just change the water in there. So that's very helpful. And then we have West Nile virus. They just found a bird in Columbia County, so that's also mosquito-related. Then the other thing, I guess that's basically it, those 3 things that I wanted to talk about. We don't have to go in depth. Does anybody have any questions on any of that?
Okay, Ron?
Okay. This has to do with the World Elder Abuse Awareness Day. That's what you're referring to, right? Okay. This is coming up on Wednesday, June 13th, from 2 to 3 o'clock at the Thompson Center on Lourdes. This is in Appleton. This is sponsored by the ADRCs of Calumet, Outagamie, and Waupaca, as well as Winnebago County. And the special guest speaker is Paul Greenwood. He's a former San Diego County prosecutor and elder rights advocate. And this is an excellent presentation that he'll be giving. They are the foremost authority, let's put it that way, in elder abuse intervention in the country, and have a real good reputation. So be a great opportunity if you're wanting to know more, learn more about elder abuse and how to intervene, to attend this event. The details are on the screen. My understanding is that when I attended the Aging and Disability Resource Center committee meeting, that there will be transportation available to this event from the senior center. Is that check out?
That's
That-
still not confirmed fully yet.
Okay, it's in the works.
Yes.
Okay, but people could contact the senior center
Yes,
to
they can.
say, hey, I need some transportation. They do want you to RSVP, and that information is on the screen as well at 236-1220, or with Nancy Rudinger, and her email address is on the bottom right of the screen. So it's an excellent opportunity to become educated on elder abuse. And just to throw something out there, would you believe that the financial elder abuse, just one area of elder abuse, bilks older adults out of about $37 billion a year. So we're talking scams and all the come-ons and all the things that are out there to try and part elderly and their money, and it's working rather well. So we got a big job to stand against that and educate our community about elder abuse and not being taken advantage of.
I don't know if you people get the Northwestern or not, but last week they had a nice article on the front page of elder abuse that showed pictures of things. And everybody is interested in it. They could have, I don't know, maybe a lot of people don't get the Northwestern paper no more, so they don't pay attention to it. But I'm glad you brought this up, but I'm going to say there was a big article talking about the state of Wisconsin here.
Yeah.
Right. There's also a program through the state of Wisconsin, and Brad Schimmel has been traveling the state to promote it, that there is a specific program. If you suspect that an elder is being abused in their home or in a facility, they have available very small hidden cameras that can be placed, and from that would be able to document such as going on. The sad thing is that a lot of families who could benefit from it have not requested those cameras.
Right. Yeah. But the key is to report elder abuse when you hear about it or suspect it, and you'd be contacting Aging and Disability Resource Center of Winnebago County to make any kind of an elder abuse report.
Right. Any other business? Sandy?
Ron, can you make them anonymous?
Yes, absolutely.
You can still do that.
Yes.
The good thing is that the agency has to investigate,
Right.
correct?
They will investigate every report, anonymous or otherwise. If, competent people can refuse that investigation, but often the ADRC then learns of individuals who have some maybe cognitive challenges and are able to offer them other services that will assist as well as stopping the elder abuse. So that's the key.
Any other?
I guess I have just one update on the
Okay.
dementia specialist
Okay, yes.
position that we talked about at our, I think our last meeting. There was a successful application. Winnebago County's going to be getting a dementia specialist position. At least they've been authorized so far. It does have a few more steps to go through for it to be on the table of organization here in Winnebago County. I'm not sure exactly where it is right now, but I know on the 19th, the county board takes up that position to approve it for addition to the table of organization. So that's the 19th of this month. It has to also have approval of the Department of Health, or Human Services Board, as well as the Personnel and Finance Committee. So hopefully, it's coming fully funded, but you don't want to take anything for granted when it's something that's being, our positions being added to the table of organization.
Okay, thank you. One other piece that I'll bring forward is Food Truck Friday, which is sponsored by the Friends of the Senior Center, and it's the third Friday of June, July, and August. There should be a poster going up. It is. And the first one is on June 15th. I talked with Judy Brewer just yesterday, and things are moving along well. There are a lot of different arrangements being made because of the construction going on in South Park, but they're anticipating having a good event, a lot of cooperation from the neighbors and everyone. So certainly encourage everyone to go. And the funds that are raised from that go for various programs and equipment at the senior center. Jean?
Correct. Yes. Yes, wonderful event. Welcome all of you. Just recently, the Friends did donate funds for the center to purchase 3 new treadmills, so which is a wonderful asset to weed out our about 12 to 14-year-old treadmills, and in the process right now of getting 3 new ones.
Okay, on that note, our next meeting is Tuesday, July 3rd. We do have one person who said they're not available that day. If you're not coming, please make sure that you let Bobby Joe know as soon as possible, so that if we don't have a quorum, we'll cancel the meeting. In the interest of the fact that it is holiday week, we've opted not to have a speaker that day, so we can spend what time we need on committee reports or some future planning if you'd like. So on that note, I will take a motion to adjourn.
So move.
Second.
All those in favor?
Aye.
Opposed? Thank you, everyone. See you next month.